Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. What we're going to be reviewing in this session are cardiac conditions and the images that they create on a chest x-ray. This is part 4. The objectives for this session are to review, identify and explain the more common cardiac anomalies and diseases or conditions which are created on a chest x-ray. And this could involve neonates, pediatrics or adults. Now, as always, when we review, you've got to remember. So we're looking at the heart on a normal AP film. We're looking at the heart size, shape and components and the position. So when we look at the heart consists of 4 chambers, 3 of which we can see on an AP film. The RA, the right atrium, the RV, the right ventricle, and the LV, the left ventricle. We can also see the vessels that enter the right atrium. The SVC, the superior vena cava, the IVC, the inferior vena cava. We can also see the hilar. The hilar is where blood vessels enter and leave. The RPA is the right pulmonary artery. The LPA is the left pulmonary artery. And we can see the 2 major arterial trunks, A, the aorta, or the ascending aorta, the aortic arch, and we can see the main pulmonary artery, which is indicated by the PA. Specifically, look at the numerics. Number 1 is the right atrium. Number 2 is the right ventricle. The apex is number 3. The SVC, number 4. The IVC, number 5. SVC, superior vena cava. Now let's review components of the left heart indicated in red. So number 5, as I indicated, was the apex, which is primarily the left ventricle on an AP film. The left ventricle and the left atrium are primarily posterior under normal circumstances anatomically and rectified or reflected in the AP film. And 6 is the ascending aorta and the aortic arch. The descending aorta not visible on an ascending or AP film. First of all, let's look at the heart size. Now when you become familiar with looking at chest x-rays, you'll get a gut feeling about what should be normal and what is not normal. However, you can use what is called the cardiothoracic ratio, which is a measurement of the transcardiac diameter and the thoracic diameter. And essentially what you're doing is measuring how wide the thorax is from end to end and how wide the heart is from end to end. The heart size indicated by the black arrow and the red arrow indicating half the thorax size. But you could measure the whole thorax from right to left, and the adult should be less than 0.5 when making the comparison. The neonate can be a little bit bigger, but it should be less than 0.65. If it's any bigger than this, this may indicate cardiomegaly. There's an example of pediatric. Measuring the transcardiac diameter, measuring the transthoracic diameter, and then dividing heart into thorax diameter. It should be in an adult less than 0.5 or equal to, and in a neonate less than 0.65 or equal to. When we look at the normal AP film and we look at the lung blood vessels, remember size, shape, components, position. And as I've indicated previously, where blood vessels enter and leave the heart are called the hilar. This is where the main pulmonary artery is located, the pulmonary trunk. This will become the right pulmonary artery and the left pulmonary artery, the hilar. This includes the right pulmonary veins and the left pulmonary veins, the hilar. And typically they're seen as off-white and not too congested, or not too white. Now let's look at the heart and the great vessels and some of the anomalies. So you've got to remember what the normal chest X-ray image looks like. That's it in front of you right now. Heart shadow less than 0.5. This is an adult or could be an older child. The hilar, right and left pulmonary artery, not too congested. This is an example of congestive heart failure. An example of pulmonary edema, which we've looked at previously. And in pulmonary edema, the lungs are full of fluid and the lungs are white. And this is as a consequence of cardiac failure. And in congestive cardiac failure, the heart image isn't nice and small and less than 0.5. It becomes congested because it's got a lot of blood in it that it can't get rid of. And as a consequence of that, you can get cardiogenic pulmonary edema, which is caused by a heart problem, or you can get pulmonic pulmonary edema, which is caused because of a pulmonary problem, such as acute respiratory distress syndrome. But essentially, the heart is big, it's congested, and as a consequence of that, the vascular markings become increased whiteness. With blood vessel congestion, venous congestion, you can develop what are called Curley lines. And Curley's lines, named after the cardiologist, are indicated by A, B, C. Curley A lines are located into the apices as little lines, interstitial edema. B are located at the costophrenic angles, peripheral edema. C are located more centrally towards the hilar. The more common ones that you would see in relation to dependence of fluid would be Curley's B lines, which are located in the peripheries at the costophrenic angles. When we talk about cardiomegaly, or an increase in the heart size, we spoke about the cardiothoracic ratio. Here we have. So therefore, the cardiothoracic ratio in an adult would be greater than 0.5, and in a pediatric or an infant or a neonate would be greater than 0.65. When we look at a big heart can be caused by certain cardiomyopathies, which are numerous. There are numerous genetic and there are numerous acquired types of cardiomyopathy. But cardiomyopathy generally is a condition in which the heart's ability to pump blood is decreased because the left ventricle becomes enlarged and it becomes weakened. Typically, it's associated with the left ventricle. Left ventricle has to do a lot of work over its lifetime. Right ventricle doesn't have to work too hard unless it's associated with some sort of pulmonary abnormality. But with cardiomyopathy, you get a big dilated heart image and the cardiothoracic ratio is greater than 0.5. When you look at mitral stenosis essentially is a narrowing or a hardening or a calcification of the mitral valve. And because of this, the opening obstructs blood flow from the left atrium to the left ventricle. It's the LAA, or the left atrial appendage, that enlarges due to the mitral valve narrowing or stenosis. And as a consequence of that, there could be backflow and outflow issues that occur. So the cardiac congestion occurs. And there's typically something called the 4 bump sign. If you look at the X-ray, there may be 4 bumps on the X-ray image because of congestion. The left atrial appendage enlarges. The left ventricle may enlarge as well. As a consequence of black flow, the pulmonary artery and veins may dilate, and this may even affect the aorta, the 4 bump sign. As I indicated, the first bump, the left atrium enlarges due to mitral valve stenosis. Blood has a back pressure to the lungs, which could cause pulmonary edema as well. When we review mitral regurgitation, which could occur as a result of mitral stenosis as well, but mitral regurgitation is an abnormal reversal of blood flow from the left ventricle to the left atrium. So instead of going forward out of the heart, it goes back to the left atrium, back to the pulmonary veins, back to the pulmonary arteries, back to the lungs, pulmonary edema. And this is caused by disruption in any part of the mitral valve. The left atrial appendage enlarges again due to mitral valve narrowing, and there could be backflow and outflow issues which could result in what is called the 4 bump sign. Again, left atrium enlarges due to mitral valve incompetence, backflow, also referred to as regurgitation. The left ventricle may also enlarge due to mitral valve incompetence and backflow. The aortic valve is another important valve that allows blood to be transferred or pushed forward out of the heart. And just like the mitral valve, it can become stenosed and it can promote regurgitation or incontinence. But aortic valve regurgitation is a condition that occurs when the heart's aortic valve doesn't close properly, not tightly. And because it doesn't close tightly, you end up getting regurgitation or backflow, or the valve becomes incompetent. And with the aortic valve incompetence resulting in regurgitation, this allows some of the blood that was initially pumped out of the left ventricle to leak back or backflow into it. This is incompetence. This causes congestion. This causes enlargement. On physical assessment, you may already hear abnormal heart sounds as a consequence of this. An aortic click, snap. But essentially on chest X-ray, the left ventricle enlarges due to the aortic valve being incompetent as a result of backflow. Cardiac tamponade is a life-threatening condition. And this is a condition that can also be known as pericardial tamponade. Tamponade, as in tampon, means to compress, to cause pressure. So a pericardial tamponade is when fluid, and this could be plasma, this could be blood, collects in the pericardium. And as a consequence of that, it compresses the heart. So the heart will be seen as getting bigger. This can be rapid, pericardial tamponade, or it can be gradual, which sometimes becomes an effusion. Remember the normal chest X-ray, which you're looking at there? Signs and symptoms of shock are associated with cardiac tamponade because the heart can't compress empty fill effectively, and this will result in cardiac output problems. It could result in shortness of breath, weakness, lightheadedness, cough, all the signs of decreased tissue perfusion, hypotension, cold pale clammy skin, sympathetic nervous system stimulation, compensation effects. Here's an example of a pericardial tamponade or a cardiac tamponade. It's hard to differentiate the fluid from the heart tissue because the fluid is white and the heart is white. The heart is radio opaque. The tissue is radio opaque. But what you can see, if you compare, is normal heart size, abnormal heart size. If we look at some of the more common congenital cardiac anomalies which adults can have, okay, they can be misdiagnosed or they may not be diagnosed until they get older in life and have some of the consequences associated with some of these congenital cardiac anomalies. So let's look at the, not simplest, but let's look at one of the more common atrial septal defects. Now, the defect in the atria is between the heart's two upper chambers, the atria, the right and left. And there are numerous atrial septal defects which we're not going to go into. Because again, with these anomalies, an echocardiogram is probably the most diagnostic tool to use to identify them. And all patients with cardiac anomalies will require an echocardiogram and possibly further investigation. The chest X-ray is the simplest, easiest tool to implement to possibly diagnose that there is a cardiac problem. Now, atrial septal defects, as I said, are defects in the septum between the heart's two upper chambers called the atria. And this defect allows oxygen-rich blood to leak or regurgitate or flow back into the oxygen-poor blood chambers of the heart, which means a left to right shunt. It's going from the left side to the right side. On a chest x-ray, you may see enlargement of the atria, possibly not. What you typically might see is pulmonary edema, increased whiteness in the lung fields, possibly cardio-megally or enlargement of the heart. Or you may see nothing until it evolves into a more serious condition as the child gets older. However, an atrial septal defect may cause typically a left to right shunt, which causes pulmonary congestion, right atrial enlargement, and cardiomegaly. You'll recognise it by the fact that possibly on physical assessment they're having breathing difficulty, shortness of breath. And this condition will cause more serious conditions, typically, if untreated, something called Eisenmenger's syndrome, which we'll look at towards the end of this course, or Learn Shop. Here's a common condition as well, called a ventricular septal defect. And as with the atrial septal defects, there are numerous defects in their location, in their severity, in how they affect the patient. However, ventricular septal defects are defects in the septum between the lower chambers of the ventricles, the right and left ventricle. And this defect allows, again, oxygen-rich blood to regurgitate, shunt, leak into the oxygen poor right-sided heart chamber, the right ventricle. So here is an example of an infant with a ventricular septal defect. Now, you can't typically diagnose a ventricular septal defect on a chest x-ray. What you can see is that they have cardiomegaly. The cardiothoracic ratio is certainly more than 0.65. Again, with a VSD, just as with an ASD, there can be a right to left shunt or a left to right shunt. A VSD right to left shunt causes the left atrium and ventricular sections to enlarge and result in cardiomegaly. A VSD left to right shunt causes pulmonary congestion, right atrial and ventricular enlargement, and cardiomegaly. However, on chest x-ray, how you recognise that will be by heart enlargement. The things that concern you are the patient's physical condition. And typically here, they would be short of breath, they may or may not be cyanosed, there would be failure to thrive because they can't take nutrition. They can't feed because they're too busy trying to breathe. Tachypnea. Tetralogy of Fallot is another more common cardiac anomaly worldwide. And in tetralogy of Fallot, this is a congenital heart defect with 4 components. They have a large ventricular septal defect, and as a consequence of the defect, the aorta isn't in the right position. It overrides the defect. There's a pulmonary stenosis, and as a consequence of the pulmonary stenosis, the right ventricle hypertrophies, right ventricular hypertrophy, and enlarges. And what you see on the chest x-ray is a boot-shaped heart, coming from the French, coeur and sabot. And this describes an upturned cardiac apex, which occurs due to right ventricular hypertrophy, and a concave pulmonary arterial segment because the pulmonary artery doesn't develop properly. On chest X-ray, a boot-shaped heart with an upturned cardiac apex, left ventricle. In Epstein's malformation or anomaly, the heart develops a classic bottle-shaped sign. Which makes it easy to recognise. However, this will require further investigation, typically in the form of an echocardiogram, maybe an MRI, further investigation. It also has what's referred to as the classic wall-to-wall carpet heart sign, because again, the heart encompasses most of the chest. The heart is huge. It goes from one end of the right side of the chest to the other side. Another common, very common, congenital cardiac anomaly is dextrocardia. And there are various classifications to this. So we're going to be looking at this generally. So dextrocardia essentially is a congenital heart defect where the heart is a mirror image of the normal heart. And there are no other problems. This is called Situs Solitus, which is the Latin which means the heart is in the incorrect position. However, the abdominal organs are sited in the right place. However, sometimes the organs of the abdomen and the lungs will be arranged also in a mirror image. For example, the liver will be on the left side instead of the right side, which is referred to as Situs or Situs Inversus. But essentially, in dextrocardia, dextro meaning right, right heart, the heart is opposite to the normal of the left ventricle. The left ventricle is placed on the right side and the right ventricle is on the left side. Dextro, right, cardia. This is an example of dextrocardia with Situs Solitus. Heart is in the mirror image position, but the abdominal organs are in the right place. The lungs are in the right place. The only thing that is wrong on this chest X-ray is the left ventricle is on the right side, dextrocardia, and the right ventricle is on the left side. Stomach you can identify by the gas bubble. Liver identified by the whiteness. Right and left lung are normal. But with further investigation, they would probably do an echocardiogram, a lung scan, etc. With Situs Solitus, the abdominal and respiratory organs are in their normal sites or position. With dextrocardia with Situs Inversus, the abdominal organs and respiratory organs are also reversed in sight. Have a look on the chest X-ray. The orientation is telling you that it's been taken correctly. Left lung and right lung have been reversed because they've probably done a scan and seen that there are 2 lobes on the right side instead of the 3 lobes. There are 3 lobes on the left side instead of the 2 lobes. Left and main bronchus are incorrectly placed. As we indicated previously, left and right ventricle are mirror imaged. Stomach and liver are also reversed. This is an example of dextrocardia with Situs Inversus. Then you've got more complex heart disease or dextrocardia. And this is called dextrocardia with Situs Ambigus, which means it's ambiguous. This is a congenital defect where the heart is still a mirror image of the normal heart, but the abdominal and respiratory organs are in an ambiguous, a strange, and an unsure sight position. It looks really weird. And this will require further investigation, more extensive investigations. On the X-ray, the vascular looks strange. You may have 2 right lungs and no left lung. You may have 2 left lungs and no right lung. You may have lungs that don't look anything like the right or the left lung. The left and right ventricle are reversed. The liver is typically in a strange position, as is the stomach, and there may or may not be a spleen, or there may be pieces or bits and pieces of spleen scattered throughout the abdominal cavity. Dextrocardia with Situs Ambigus. But essentially on the chest X-ray, what you can see is a very strange looking heart. Another complex, not common, cardiac condition that results as a congenital anomaly is hypoplastic left heart syndrome. And this is a congenital heart defect that affects normal blood flow through the heart. The left ventricle is typically small or missing. The mitral valve is absent or severely malformed. The aorta and its valve is malformed, or it could even be missing. The patent ductus arteriosus is present and functioning. If it wasn't, the infant would probably die at birth. So a variety of chest X-ray findings could include cardio-megally from right atrial hypertrophy, pulmonary venous congestion, an atrial septal defect, and mitral valve stenosis or atresia, in addition to all the other previous things mentioned. It's very complex congenital anomaly. On chest X-ray, the heart will be big, despite the fact here that there's a small or no left ventricle. There may be a small or no ascending aorta. The arch may be sort of missing. There will be right atrial hypertrophy, because the right heart has to work very hard in order to meet metabolic requirements, which are typically met by the left ventricle. And there will typically be pulmonary congestion. The infant will not be very, very well on physical assessment. Another common condition is related to the great vessels. And if we look at the aorta and the pulmonary artery, we can have something that is called persistent patent ductus arteriosus. And this is a medical condition in which the ductus arteriosus fails to close approximately 24 to 48 hours after birth. And in this condition, some of the oxygenated blood from the left ventricle flows back to the lungs because of the higher aortic pressure to the lower pulmonary artery pressures. And this can be demonstrated in a bump, which is called the ductus bump sign, or the ductal diverticulum. And this usually appears as a small focal bump with gentle obtuse angles on the aorta. And this could be seen in the newborn. Not always seen but it could be seen. Then you've got other anomalies related to the great vessels, such as truncus arteriosus, and there are numerous different classifications. I'm not going through the classifications. However, truncus arteriosus is a medical condition in which a single blood vessel, the truncus arteriosus, which is a single combined aorta and pulmonary arterial trunk. Embryonically, they didn't separate into the aorta and into the pulmonary artery. And this trunk then comes out of the right and left ventricles as one vessel. There's a large VSD usually associated with it because the septum doesn't form either. And this trunk is the result, instead of normal pulmonary artery and aortic divisions. And as I said, there are numerous different types of classifications. What you see on chest X-ray are possibly a widened mediastinum where the aortic arch and the pulmonary artery are combined. However, on physical assessment, this would be noteworthy. This typically becomes a cyanotic cardiac anomaly where the infant will be cyanosed and require further investigation. Echocardiogram, CT, ultrasound, all investigations that could be considered. Aortic arch and pulmonary trunk anomalies could be identified on chest X-ray, which will lead to further investigations. Let's look at coarctation of the aorta, which is a medical condition where the aorta is narrow or constricted in portional section, and again there are numerous types of classifications. However, the anomaly is in the aorta. On chest X-ray, there are numerous signs that can be employed, which could be, for example, here the aortic arch, the knuckle, the knob isn't really visible, and it may be seen as being flat. There can be a sign called the number 3 sign, where you get the bumping of the aorta or the arch because of the constriction or the coarctation, which again is the narrowing. Instead of it being smooth in the aortic arch and the descending aorta, you get this notching effect, the number 3 sign. Or you can get what is called Dock's sign, which occurs because of rib notching caused by pressure from the dilated intercostal arteries because of outflow problems in the descending aorta. And if you look at the chest X-ray, if you look at the ribs, these are posterior ribs, you can see little notches indicated by the arrows, which is where the intercostal arteries have been putting pressure on the ribs and wearing them away. Oh, look, there's a danger as well here that the arteries could erode and cause catastrophic bleeding. Dock's sign. Another anomaly related to the great vessels is called dextro-transposition of the great arteries. Dextro, remember, meaning right. Transposition is change in position of the great arteries, pulmonary artery, aorta. And this is a birth defect where the pulmonary artery and the aorta are switched in position. They're in the wrong place. The aorta is connected to the right ventricle and the pulmonary artery is connected to the left ventricle. So that's a problem, because that means deoxygenated blood goes to the right ventricle and is pushed out into the systemic circulation. So the body actually doesn't get any oxygenated blood. On the reverse side, on the left ventricle, the oxygenated blood coming from the lungs goes to the left ventricle and is pushed back to the lungs. And unless there is now an abnormal connection like an ASD or a VSD or a ductus arteriosus, the infant will die probably immediately because there's no oxygenated blood going to the tissues. However, on chest X-ray, you'll find increased vascular markings because the aorta is sending too much blood to the lungs. There's a narrowed mediastinum because the pulmonary artery and aorta are parallel, and you can get what is called the egg on a string sign. The egg on a string sign basically means the heart looks like an egg, and the upper portion of the mediastinum is really narrow because the narrow mediastinum is the result of the arteries being parallel. And as a consequence of now increased blood flow to the lungs, there are increased vascular markings. The egg on a string sign. The infant won't be very well. Then you've got certain anomalies, which I've just chosen for interest. The great vessel anomalies, a right aortic arch. So you see the aortic arch, or the aortic knuckle, or the aortic knob on the right side, instead of on the left side where it typically is. A right aortic arch occurs when the aortic arch transverses over the right bronchus instead of the left bronchus, which typically it does. On a chest X-ray, you may see a right-sided aortic arch. The aortic knob is located on the right instead of the left. Then you've got more common anomalies related to aging adults. And a thoracic aortic aneurysm is one. And a thoracic aortic aneurysm is a weakened area in the upper part of the aorta, remembering that the aorta is a major blood vessel that supplies oxygenated blood to the whole body. The chest X-ray findings are typically widening of the mediastinal silhouette, an enlarged aortic knob, possibly displacement of the trachea from the midline, which could result in mediastinal shift as well. So on the chest X-ray that you can see, you've got knob enlargement or a mass there. Looks like a mass, which is what an aortic aneurysm is. And if it's in the thorax, it can push the trachea, tracheal deviation, and on image can cause mediastinal widening. So let's review some of the cardiac conditions and anomalies on chest X-ray. Again, as previous, always evaluate the X-rays in light of the patient's history, their physical assessment findings, their clinical findings, how they're feeling, what they're experiencing. If possible, review the chest X-rays serially, because things may have changed over time, acute versus chronic. And always remember the technical quality, especially with the congenital cardiac anomalies. When you've got situations like Dextrocardia, make sure that the radiographer has labelled the X-ray correctly, that says this is the right side, this is the left side, especially when the heart position has been reversed, because sometimes they make mistakes as well. Everybody's human. Okay, what do you think? Left ventricle looks like it's on the right side. liver and stomach look like they're in the right position. This would be Dextrocardia with Situs Solitus. This one we didn't discuss really, but you could probably interpret this as possibly someone with tetralogy of Fallot. However, they're not. It does appear to be a boot-shaped heart, but it isn't the classic. This is actually someone with a left ventricular aneurysm. Enlargement in the left upper lobe around the aortic arch, knob, knuckle, descending aorta. What do you think? This is a thoracic aortic aneurysm. Yep, I think you're correct. This is a right-sided aortic arch. Think of the sign, egg on a spoon. A heart that's shaped like an egg, a narrowed mediastinum. This is dextrotransposition of the great arteries. Okay, this is your infant with a boot-shaped heart, or what could be considered a boot-shaped heart, which will also require further investigation, but this would be an example of tetralogy of Fallot. Okay, what do you think? Stomach's under the right hemidiaphragm. Liver is under the left hemidiaphragm. The heart, main portion, is on the right side. Orientation's correct. It indicates that this is the right side. The lungs appear to be transposed. This is Dextrocardia with Situs Inversus. Then you've got an X-ray which is highlighting either a flat knuckle, a number 3 sign, and doc sign. All three are there. Correct. Coaptation of the aorta. Then you've got a huge watermelon heart, which is demonstrating the bottle sign. Oh, you could even refer to it as wall-to-wall heart. You've got a huge heart. This is Ebstein's anomaly or malformation. And last but not least, this is now a heart that's indicating the 4 bump sign, which could be one of 2 situations or more. This could be mitral valve stenosis, or it could be mitral valve incompetence or regurgitation. Okay, that brings us to the end of part 4 in chest X-ray interpretation. I hope you found it interesting. I hope you got something out of it. And if you're interested, follow to the final Learn shop of chest X-ray interpretation, which is part 5, and deals with invasive line placements, correct and incorrect. And if you're interested in any other Dr. Manny Learn shops, you can locate those on YouTube as well. Thanks a lot.